get started with the activity. Okay, over to you, Jenna.
Thanks, Maureen. Hello, good afternoon, everyone.
Hi.
Happy sunny Monday afternoon. I'm happy to be here with you today. As Maureen mentioned, my name's Jenna. I'm a respiratory therapist and respiratory educator. I currently work at the VGH Pulmonary Rehab Program, which is an exercise and education program for clients living with lung disease. So I'm going to bring part of what we do in class to you to get us moving and exercising this afternoon, sorry. So before we continue, you do not need any equipment for this session, but if you do happen to have some hand weights that you do want to use, you can do that, and I will provide that option. Before we exercise this morning, just some safety reminders. So you will need a nice sturdy chair, so nothing that has any wheels on it. The only space that you need is the space of your chair and the ability to kind of move to the front, back, and to each side of your chair. So just take a look around, make sure there's no tripping hazards. Just check in that you are feeling that you've got some non-slip footwear on, or your floor doesn't feel too slippery. Some water handy for sips of water if you like, and you've got your oxygen at your right level, and I think that's it. I think we should be ready to go. And also just keeping in mind you're in a nice, well-ventilated space. So if you need to open windows or have fans on while we exercise today, please do that. So I'm going to be building on some things that you've already learned with the Better Breathers Club. We're going to be using our purse-lip breathing today to help us breathe through these exercises. And you're going to be using your Borg scale, or that shortness of breath scale. So that scale from 0 to 10, 0 being not short of breath at all, 10 being the worst shortness of breath you've ever felt. And we're trying to exercise in that area between a 3 and a 5. So working on trying to get to that area today if you can. So without further ado, let's get settled in seated position. We're going to sit up nice and tall. We're going to relax our shoulders down, try and relieve any tension we might feel in our neck and our shoulders. We're going to start walking. So here we go. We are pumping our arms. We are walking our legs. Move a little more back so you can see. And this is just an easy pace walk to get us warmed up as we settle into our breath. So here we go. In through the nose, out through the mouth. Good. And again, in through the nose, out through those pursed lips. And just trying to focus on exhaling a bit longer than it took you to inhale. And as we walk here and seated, just being aware again of our posture. So trying to sit up tall with that flat back. Relaxing tension, that sneaky tension that can get into our neck and our shoulders. And perhaps even setting an intention for our exercise today. How do you feel? How does your body feel? How does your breath feel? Are things feeling pretty good? So can you exercise perhaps close to that Borg scale of a 4 or 5? Or are things not feeling so great? And you're going to move with us today, for perhaps you use your breathing technique and you exercise more at a 3 or 4 on the Borg scale. So setting that intention for yourself, and let's release here. Wonderful. We're going to stretch things out from head to toe. So we're going to do ear to shoulder, relaxing those shoulders down and just dropping the head, getting into those neck muscles, and a nice deep breath here. Good. Coming back up to center, other side, ear to shoulder. Relaxing those shoulders down, just letting the head hang here. And a deep breath. Beautiful. Coming back up to center. We're going to look side to side. So at your own pace. From one shoulder to the other. And finding a rhythm of breath with this movement. Perhaps you breathe in at one shoulder. Perhaps you exhale as you move to the other shoulder. So whatever rhythm of breath works for you. Let's do a couple more. We'll do one last one and then come back to center. Great, and release. All right, let's get into our shoulders. These shoulders come up to the ears, down and around. So rolling our shoulders forward. Good. Let's do that 5 times. Then we're going to switch to rolling our shoulders backwards, up to the ears, down and around. Feeling those shoulder blades drop down your back. Wonderful. And we're going to release there. We're going to take our arms, stretch them out in front of you. We're going to rotate our wrists in one direction. So perhaps you're rotating them outwards. Looking good. Beautiful. Couple more, and then we're going to start to rotate them inwards. Finding a rhythm of breath again. Good. And then we're going to take our fingers and they're going to go up to the sky, down to the floor. Yeah, you could give them a wiggle if you like. Good. Up and down. And one more. Good. All right. So we're going to get down into our trunk now. So we're going to do a little bit of a twist. It's a gentle one. If you have tenderness in your lower back, just be careful of this one. I forgot to mention at the start, so at no time should you feel any pain. So if you feel pain, please come out of whatever movement it is that's causing you the pain. So for this twist, we're going to put one arm straight out in front of us, and we're going to have one arm out to the side. Okay, shoulders relaxed down. We're going to look towards our side arm. We're going to take a breath in, and as we exhale, we're just going to do a little quarter twist. So looking, that arm moves a little behind, but we keep looking down the barrel of that arm and we breathe. Trying to keep those shoulders relaxed down. One more breath. And then we're going to twist back to center and release our arms. Nice job. So now the other side. So now that arm that was out to the side, that arm is out to the front. Okay, other arm to the side. So we're like a letter L. Looking down that side arm. Take your breath in. As you breathe out, twist gently. Keep breathing and relax those shoulders down. Wonderful. Twist back to center, release. Nice job, everyone. Heading down to our lower body. So we're going to get some movement in our legs. So sitting back in your chair, just some leg extensions. So we're going to extend the leg straight, release it, extend it straight, and release. So again, finding a rhythm of breath that helps you with these movements. For everyone, it might look a little different. So for me, I'm breathing in when my feet are down together. I'm breathing out as I extend that leg straight. Wonderful. Keep going. Good. Let's do 2 more on each side, on each leg. Good. Last one. And let's release there. Wonderful. Sitting back in the chair a little bit so that you can bring your ankles up off the ground. We're going to extend our legs forward a bit. And we're just going to rotate our ankles outwards in one direction. Good. And we're going to rotate our ankles inwards. So just changing the direction of these ankle rolls. And then we're going to take our ankles and we're going to do toes up to the sky, down to the floor, like you're hitting that gas pedal. Here we go, up and down. And again, finding that rhythm of breath that works for you with this movement. One more, and then let's release. Wonderful, nice job everyone. So grab a sip of water if you like. We are going to head into a bit of an aerobic movement. So I'm going to lead you through a minute of exercise that's meant to get your heart rate up a little bit. This exercise can be done in seated or standing. I'll show you both options. So please choose the option that feels steady and strong for you, knowing that even if you start off in standing and it's not feeling so good, you can come down into seated at any time, okay? So these movements have an upper body movement and a lower body movement at the same time. Our upper body, we're going to put on our boxing gloves. So channel whoever your favorite boxer is, and we're going to box. So a couple punches out into the air. We're going to rest, and then we're going to march or jog, okay? So it's going to go punch, 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 run, 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 punch, 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 run, 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 run. If this is hard on your hips in seated, please come up into standing if that is a stable option for you. Same idea, knees are soft, punch, 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 run, 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 punch, 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 run, 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 run. And that run can be a walk as well. Okay, so I'm going to join those in seated for this one. And just going to restart our timer here. So here we go, using our pursed lip breathing. Punch, 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 run, 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 run. Nice job, you guys. Keep going. So find your rhythm of breath with this one. When does it feel comfortable to breathe in? And can you breathe out 3 or 4 times as long? Good. Keep going. We've got about 15 more seconds. You're doing great. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Release. Nice job. Okay, so resting position. So after those aerobic type exercises, go into your resting position. So chest forward a little bit, nice and relaxed in the arms and shoulders. Pursed lip breathe until you feel that you're in a nice steady Borg scale of a 3 to a 5. Good. All right, when you're feeling ready, we're going to move on to some arm strengtheners. So anyone who needs a longer just to sit in pursed lip breathing, please do that. Join in at any time you feel ready. So for our arm strengtheners, we don't need any weights for this. But if you've been exercising and you're feeling good and you're looking at progressing your exercises, if it feels like it's a bit too easy, you can grab some hand weights and do these exercises with the hand weights. So we are going to start off in seated, sitting up tall, shoulders down, arms extended out straight. we're going to take our palms, hitting my closet here, sorry. We're going to take our palms and we're going to face our palms upwards. And we are going to pulse our arms for 10 seconds. So pulsing means just small movements up and down, okay? And we're going to breathe our pursed lip breathing as we do this, okay? So here we go for 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Take those palms, face them forwards. Here we go. We're going to pulse again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Palms down. We're going to pulse again. This time, how do your shoulders feel? Are they relaxed down or are they starting to creep up a bit? So check them down as we pulse. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We're almost there. You're doing great. Take those palms, face them back. Here we go. Last one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And release. Woo! Nice job. So give your shoulders a shake. We are going to go into a strengthening exercise for the back arm muscles, our triceps, okay? So you could do this in seated. So you're gonna lean forward a little bit. So just hinging from your hips, shoulders down, back is flat, okay? Arms are very close to your side body. So you're gonna extend your arms back. Hold it there for a couple of seconds. Feel the strengthening or engagement in the back of the arm muscles, and then we're going to curl them up. Okay, so here we go. Take a breath. As you breathe out, arms extend back. Hold for a couple of seconds. Curl them up. We're going to continue to do this 10 times. Breathe out, push back, and curl up. Good. So find your rhythm of breath. So one of the most important things when we're exercising or when we're doing something hard is trying not to hold our breath. It's natural for us to feel like we want to do that, but really use your pursed lip breathing to help you through. Good. We've got 3 more. Okay, so for me, I'm breathing in when I curl my arms up. I'm breathing out as I stretch or push my arms back. Good. 2 more. And last one. Wonderful. Release. So come back to sitting up tall and take a deep breath. All right, next exercise, we're gonna do something for our biceps here, okay? So again, you could do this without weights or grab a weight if you feel like that's what you would like. So we're gonna come up into a bicep curl. So we're just curling our arms up and then keeping our shoulders down. And then our elbows are gonna come up like chicken wings. And then we're gonna release it down and release it down. So here we go for 10. Curl up, elbows up, release, and down. Good. Find your rhythm of breath with this movement. For me, it feels good to breathe in as I release down, and I'm gonna exhale as I do the hard part, which is curling my biceps up, my elbows out, and then I breathe in again. Nice job. Now, I don't know if you realize what I've done here, but I've got you all inadvertently doing the chicken dance. And you're looking great. Nice job. Keep going. Use your breath. All right. I lost count here a little bit. Too preoccupied with the chicken dance, but let's do 2 more. Here we go. 2. And last one. Looking great. Release. Good. All right, we're going to shake that out. So last arm exercise, And then we're gonna head into an aerobic minute where we get our heart rate up a little bit more. So we are going to do chest press with a heel tap. So with this one, upper body, sorry, let me fix my video. So getting into the chest muscles here, so we're pushing out, coming in. When you do this, you should feel like your shoulder blades are coming forward and then shoulder blades are moving back. So they're trying to kind of touch each other in the center of your spine. That's the action we're going for. Now, lower body, to make it a little bit harder, is we're gonna do a heel tap, okay? So as you push out, one foot will tap its heel, and then as you come in with your arms, so does your foot. And then you're gonna push out again, now with your alternate foot. And as you come in, arms and legs coming in together, okay? So this can be done with weights or no weights, but we're gonna go for 10. So here we go. Feeling that shoulder blade action in your back. Shoulders are relaxed down. Good. Now, how is your rhythm of breath? Good. For me, I am breathing in when my arms come close to my body, and I'm breathing out as I push out. Good. Wonderful. Keep going. Okay, go at a pace that works for you. We've got 4 more. 3. Try and keep those elbows really close to the side body. 2. Last one. Wonderful. Release out of that. So sip of water if you like. We're gonna head into an aerobic minute. Again, this can be done in seated or in standing. So for this minute, we are going, upper body is going to be reaching across the body, pulling it in. Reaching across the body, pulling it in. So this is what the upper body is doing. Lower body is sidestepping. So if you are in seated, you're up in your chair a little bit. You're gonna step out to the side as that arm on the same side reaches across your body, and then you're gonna pull it all in. Other side, side steps as your arm reaches across the body, and then you're gonna pull it in. So if you're in seated, this is what it looks like. Okay, going at a pace to keep your shortness of breath scale between a 3 and a 5. If this is hard on your hips or your back, you might want to come into standing. So for this one, I'll join those in standing if that feels comfortable and stable for you. Okay, so here we go for a minute. Reach, bring it in. Reach, bring it in. Here we go. Looking great, everybody. Wonderful. Okay, if you're in standing, you're just soft in the knees. Now, how does the intensity feel? Where is your Borg scale? So if you're low on the Borg scale, maybe a 1 or 2 in terms of shortness of breath, can you speed it up a little bit? And if you are feeling, you know what, Jenna, I'm already at a 5, then maintain and use your pursed lip breathing. Wonderful, keep going. More than halfway. You guys are looking great. Right? How is the breath? In through the nose, out through the mouth, breathing out longer than it took you to breathe in. Here's our countdown. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Release. Nice work, everyone. In seated resting position. Slow your breath down. So remember your resting positions. You can lean forward a bit, chest cavity dropping open, relaxing neck and shoulders, elongating the exhale. Nice job. Okay. So as always, take as long as you need in resting position to get your Borg scale, somewhere between that 3 and a 5. We're gonna go on to some lower leg exercises. So we're gonna start with some heel raises for our calf muscles. You can do this in seated, okay, or standing. So for seated, you're sitting up in your chair, feet are about hip width apart. You're gonna come up on your toes and really concentrate on those heels slowly coming down. So we can do this fast if we want, but we're probably not gonna get much strengthening from that. So really focus on up on your toes, focus on those heels slowly coming down, and try for 10 of those. If that feels like you want a little bit more and you're stable and standing, you can do this holding onto your chair. So standing behind your chair, hands on chair, feet hip width apart, soften those knees, up on your toes, heels slow to come down. And just being mindful that we want the strength to come right from our legs, and we don't want our hips to kind of swing us up into the pose, okay? That's too easy. So if you're in standing, nice and strong in those lower leg muscles, okay? How's your rhythm of breath? So for me, I'm inhaling as I come up, exhaling as I slowly come down. And let's just do 2 more. Good. And release there. All right. Coming into seated. Okay, we're going to do a strengthener for our inner thigh muscles. We're going to use our wrists for this. So 2 fists, okay, in between our thigh muscles. If this is crampy for your fingers, if it doesn't feel great to hold a fist, you can use a cushion or a pillow in here, okay? So coming into good position, so we're sitting flat back, shoulders down. We've got our 2 fists, put them in between our thighs. And we are going to squeeze our thigh muscles in for a couple seconds, and then we're going to release them. And we're going to cycle through that a couple times. So working on strengthening in our inner thigh muscle. Now just be aware as you do this one, really focus on these inner thighs, strengthening, and try not to use, really try and focus in on these muscles because that's what we're trying to target. So here are our fists. Let's squeeze. 1, 2, 3, and release. And let's squeeze those inner thigh muscles. 1, 2, 3, and release. Now here's the tricky part. How is the breath? So even though our thighs are squeezing, we don't want to hold our breath with this one. So can you find a rhythm? In through the nose, perhaps out through the mouth as you're squeezing your thighs. 2 more. Squeeze and release. And let's do one last one. Squeeze and release. Beautiful. Shake out your hands, shake out your legs. All right, so just looking at the time, I'm going to lead us through one more leg strengthener, and then we're going to head into some cool down stretches. So You know what? I have to say, I think this is one of my favorite leg strengtheners because it's kind of fun, but it does really work your body. So we're going to sit back in our chair and we're going to trace the alphabet in the air with our feet. So we're going to extend one leg straight out in front of us with a slight bend in that knee. So just be careful you're not locking your knee. And pick uppercase, pick lowercase, whatever you like. And let's trace from the letter A to the letter M in the air. Here we go. Okay, so this is a really good one when you are, anytime you're in seated and you want to work on a little bit of leg strengthening. So remember, when we strengthen our legs, we also work on trying to reduce our risk for falling. So this is a good one if you're in front of the TV. You could pull this one out. Good. All right, I'm about halfway through there to M. So I'm going to release my leg down there. And then I'm going to extend my other leg straight. And I'm going to trace from N to Z. Here we go. As always, find your rhythm of breath. Make sure you're not holding it in. Good. Keep going. All right. I'm at Z and release. Wonderful. Shake it all out. Thumbs up if you're feeling all right. Wonderful. Good. So let's just march it out for a little bit. And then we're going to head into some nice cool down stretches for you. So, this routine, as you notice, mostly done in seated. Really good complement to if you go out for a walk and you find a nice park bench, kind of going through some of these strengtheners and then walking home. That's a really nice routine for a nice sunny day if you can manage it. So hopefully it's given you some ideas. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. All right, so we're going to stretch out our arms a little bit. So you could take your one arm, come around, grab your elbow, okay, check your shoulders down, and just pull that arm just across the body a little bit, making sure that this shoulder gets checked down. And you can feel a stretch across the shoulder, upper back. If you don't really feel it and you feel like you want a little bit more, you can use your other arm to just kind of hug that arm into your body and breathe. Good. All right. Release. Okay, we're going to do the other side. So elbow, with your other hand, come around, grab that elbow, pull it across the body. Okay, shoulder check down and hold there and breathe. Good. Wonderful. Good, and release. One for the tricep, so arm extended up straight, close to the ear, bend at the elbow, and you could pull that arm back and down, okay, checking that shoulder down a bit. Now, if this is too much for your shoulder, you can also do this one, which is hand on shoulder, and using your other arm to kind of help that elbow come up a little bit more. So if your shoulders will let you, this is where you are up here, checking shoulders down. And if your shoulders will not let you, you're staying about shoulder height and breathe. Good. Release. Other side. Arm up close to the ear, bend at the elbow. Pull that back down a little bit. Nice big deep breaths here. You got it. Good. And release. And let's just do one for the legs, and then we're going to close with some deep breaths here. So lower body, I'm going to stretch out the back of the leg a little bit. So we're sitting up in our chair, feet about hip width apart, extending one leg straight, but keeping a nice bend in the knee here. From the hips, so keep your back nice and straight, arms forward, and we're just going to kind of hinge a bit forward from the hip. Okay, now when you do that, you should start to feel a stretch down the back of the leg. All right, and breathe here. So this is a good one to stretch out the hamstring, the back of the leg muscle, without putting too much pressure on the abdomen. Another breath, and then hinging from the hip again, come back into seated, release your arms, release your leg, and other side. So next leg extended straight with that slight bend in the knee, okay? Back is nice and flat, so sitting up tall, shoulders down. I'm gonna take those arms and just sort of reach forward, feeling hopefully a nice stretch in the back of your leg, and breathe. Wonderful, one last breath. Come back up into sitting up tall, release your leg. All right, and then let's just do a couple deep breaths to end us off however you like. So take a deep breath in, arms can come up if you like, and breathe out. And in, and out. And last breath in, and out. And then arms around here like a hug, and give yourself a nice pat on the back because you did a great job today. Nice work, everyone.
All right, thank you so much, Jenna. I hope everyone enjoyed that. As always, we are recording our webinar, so this will be available on the BC Lung website for on-demand viewing at a later date. So if you want to revisit that and sort of use this video as a guide, if you want to sort of do this again on your own time, that will be available on, like I said, on the BC Lung website. So once again, thank you so much to Jenna. Does anybody have any questions for Jenna at all? I know she has to run because she's got patients. So we really, really appreciate having you, Jenna. Thank you so much. And yeah, I guess we will switch over to the next part of our webinar, which is our
That was fun, Jenna.
Finnis. Thanks, Jenna. We'll see you later.
Thank you, Jenna.
Everyone. Have a great
Take care.
afternoon. Bye-bye.
Bye-bye now.
All right. So yeah, so we are going to get going to the Q&A part of our webinar. So who I introduced very briefly at the beginning, but I will get him to tell us a little bit more about himself. Okay, go ahead.
Thanks very much, Maureen. Good afternoon, everybody. I certainly recognize a few names out there, and I look forward to meeting a few other people today. So this is great. I know we've got somebody from Vernon. That's fantastic. So yeah, I'm a respiratory therapist and respiratory educator, just as Jenna is. My primary focus, however, really is on the educational side of things. I'm not nearly as knowledgeable or experienced with regards to the practical part of doing the exercises. I am certainly happy to entertain any questions as they relate to COPD itself, whether that's the diagnosis of COPD or asthma COPD overlap, that interesting situation where people can essentially have two different lung conditions going on. We can talk about inhaler medicines, the importance of inhaler technique, and certainly a couple of things that I would admit are probably two of my personal passions, because I see the absolute value when I talk to people, and that is the importance of breath control, so pursed lip breathing, pacing, and postural techniques, as well as the whole concept of action plans for COPD, meaning how do people know that they're getting into trouble and what do they do about it? So there, that was a bit of a longer introduction. Now, Maureen, I believe you have some questions on a slide that people had submitted ahead of time.
I do. Okay, so I'm just putting them up now. I hope you can see that on your screen. Okay, so let's get started with the first one. Okay, so what is COPD and what are the risk factors?
Wow, that's a good big topic of conversation. Now, one thing I would like to confirm, actually, just before I start, is our end point 3 o'clock today? Is that correct?
We end at 2:30 today.
2:30. Okay, so we got 45 minutes. Okay, so what causes COPD? What are the risk factors? Really, really good. Certainly, over the years, it has been understood that cigarette smoking was the primary cause for COPD. However, it is now understood that many things can actually cause COPD. So if somebody was a real egghead and they were wanting to look at literature from GOLD, for example, which is the Global Obstructive Lung Disease Group, they actually took out cigarette smoking as the primary cause of COPD, because in most of the what we might call the developing world, COPD is caused by the burning of biomass, meaning many people burn wood inside of their home to heat or cook food. And so one of the populations of people where you can actually see COPD would be in women who do not smoke, but they have lived inside a small building, for example, hut, and they've been cooking over a wood fire for 30 to 40 years, and they essentially have COPD from the burning of that biomass or that wood smoke. So the reality is that in the developed world, or certainly looking at Canada, for example, yes, the primary cause of COPD still is cigarette smoke exposure. Causes about 80% of the cases of COPD that I would see. The reality is other things can also cause COPD, so we must be mindful of that. In other words, workplace exposure. I can see people who have never smoked a day in their life, but they may have worked in a sawmill. They may have worked in a factory. They may have worked in construction, concrete dust exposure, silica exposure, auto body, for example. And people definitely can develop lung disease because of what they do. And that's why we're meant to have WorkSafe BC there to keep air quality at a sufficient level, meaning a high level of air quality, so that people don't develop lung disease after 20, 30, 40 years of a career. In terms of the risk factors, well, we've already talked about cigarette smoke as a risk factor for developing COPD, the primary one at the moment, but the other ones would be what a person does for a living. Then there's, of course, the unique particulates that are out there, meaning certain particulates are far more problematic to cause COPD than others. So certainly, if you look at, well, let's just look at cigarettes. So if you look at cigarettes, there are so many chemicals and particulates in there that damage the lining of the breathing tubes, what we would tend to think of as the chronic bronchitis part of the problem, cough and spit. And then the other part of the problem caused by the particulate exposure is emphysema, or damage to the air sacs of the lung. Well, other types of industrial exposure can cause that, or even looking at secondhand smoke exposure when smoking was common in workplace offices or even in restaurants, etc. The other sort of group that you could look at in terms of factors that would come into play are genetic, meaning alpha-1 antitrypsin deficiency is a quite uncommon genetic abnormality that is known to result in significant emphysema. The reality is alpha-1 antitrypsin deficiency doesn't cause a significant amount or a number of people who have COPD, if that makes sense. Meaning, if you looked at the people who had COPD and then you looked at how many people actually have alpha-1 antitrypsin deficiency, it's very, very low. So clearly there are what we would call sort of genetic susceptibility or risk factors, most of which aren't known. The ones which would be known would be if a person has asthma, for example, they are more likely to develop COPD if they smoke or if they work in an environment where they are exposed to particulate. Somebody that has underlying cystic fibrosis, for example, much more likely to develop very, very rapidly progressive lung disease. So there certainly are familial traits where there must be something involved in the gene being passed on from, parent to parent, parent to child, et cetera, et cetera, et cetera. But they're just not known yet. They haven't been identified. Because certainly what respirologists will do, they'll say, is there anybody in your immediate family whoever had lung disease, whoever had asthma, whoever had, COPD, for example? Oh, yes, my father, my grandfather, my sister, my brother. Clearly, there's some sort of genetic story there, whether or not it is specifically alpha-1 antitrypsin or whether it's because of underlying asthma in those people or other factors. Clearly, genes play a role, but what they are, they're not sure. So hopefully that was a bit helpful. So sorry, what are the symptoms of COPD? Yeah, this is always also an interesting question in that the symptoms of COPD can vary a lot. So the classic symptom of COPD that typically is universal for all people who have COPD is shortness of breath. So when I'm doing one of these discussions with people and I say, anybody who experiences shortness of breath when they walk, please put up your hand. And essentially everybody puts their hand up. Now, every now and then there are a few people that don't put their hand up, meaning they don't really complain a lot about the symptoms of COPD, specifically shortness of breath. And for some people, that's actually, in many ways, you could say, because they're quite clever and they avoid doing things that make them short of breath, so therefore they don't really do anything, meaning they're not very active or they're more sedentary to minimize the burden of their shortness of breath. Now, clearly we can all see what the complications are for that leading, down the road. So certainly the primary symptom, the universal symptom, is shortness of breath. The other symptoms of COPD that for some people would be common, but not all, would be cough, wheeze, chest tightness, or mucus production. So those are sort of the classics: shortness of breath, cough, wheeze, tightness in the chest, mucus production. And in the past, so I see Doreen's question, can asthma cause more symptoms than emphysema? We'll talk a little bit about that. So remind me of that, Doreen or Maureen. What I was going to get at with regards to those 5 symptoms that I outlined before is, in the medical community, as you probably know, there are what we call phenotypes, or different ways that diseases will express themselves in terms of symptoms. And so from our perspective, we definitely are familiar with these particular terms, and they're not meant to be pejorative or critical or making fun of anybody, but we would use the term chronic cough and spit, or sort of the blue bloater is the old picture or thought of people with chronic bronchitis. It's really the cough and spit that I'm referring to. So some people with COPD will say they wake up in the morning and they have quite significant mucus. They cough it up, and yet they still cough it up through the day. Or as a general statement, they would say, yes, coughing of mucus, chest tightness, wheezing, common symptoms. So cough with mucus production. Other people are more what we might call the pink puffer, or much more the breathlessness type of scenario, meaning more emphysema. So that person would typically, or quite often, say they don't have a lot of mucus. They don't cough a lot of mucus on a regular basis, but breathlessness and tightness of the chest is their most primary complaint or symptom. And these two extremes happen in some people with COPD. Again, respirologists don't really understand why, but for some people, when we do the breathing tests or when they have a CT scan of their chest, there isn't a lot of evidence for widespread emphysema or destruction or damage of air sacs. Emphysema. It's mostly confined to the breathing tubes. So they have COPD, which is confirmed by the blowing test, meaning an abnormality of how air empties out of the lung, but their primary problem really is with the breathing tubes. Narrowing of the breathing tubes due to chronic inflammation, mucus production from the goblet cells, mucus that is greater in abundance and thickness, and then muscles that can go into spasm. So the cough and spit type of picture. On the other hand, some people do have predominantly what we would see as emphysema. So they have a CT scan and there's very, very significant damage to the air sacs of the lung, the alveoli, whether it's mostly in the upper lobes, the lower, or quite diffuse through the lung. And for some reason, that's the way COPD tends to manifest in those people. More related to damage to the air sacs, not so much the breathing tubes in terms of cough and spit. So again, in summary, the primary symptoms of COPD, shortness of breath, almost everybody would complain about that, and then varying combinations of chest tightness, cough, wheeze, mucus production. Doreen, then, if I could just back up just 1 minute, Maureen. Doreen had a question talking about asthma versus emphysema in terms of can people have more symptoms with asthma. One of the things that we must keep in mind when we think about shortness of breath as a symptom, if a person had what we call pure asthma, if there ever is such a thing, pure asthma means it's inflammation or potential damage purely to the breathing tubes of the lung, meaning there is no involvement with the air sacs, meaning there is no emphysema in the lung in a person that has pure asthma. So therefore, the vast majority of people with asthma, except if they're very, very acutely ill, they could feel quite breathless with activity, but their oxygen level will be normal. So breathlessness in the vast majority of people, especially people with asthma, breathlessness is about too much air in the lung, air trapping, and inability to empty the lung. It's not about oxygen absorption. So shortness of breath does not match well with oxygen levels being low, right? Meaning, if I get short of breath walking up a hill and I have asthma or COPD, would I expect my oxygen levels to be low? No, typically we wouldn't. So I can get into that a little bit later when I talk about breath control techniques. I know there was a question that popped up on the bottom of the screen, but my little pea brain couldn't read it and think about what I was saying at the same time. But I'm sure Maureen will have a note of it, so she can prompt me. So here's the question: what is an exacerbation or flare-up, and how do I know if I'm having one? Brilliant question. As I mentioned in my introduction, this is one of my areas of particular interest, and by that I don't mean that I would dominate a conversation with a patient to this and ignore everything else. I say this simply because this is a difficult question. I've had a few patients in my career, in my live Living Well with COPD programs, when I would have 10 or 12 people in a room, and a few people get quite upset and point their finger at me and saying, "What are you telling me, that I have to be a doctor? I don't know medicine. You're telling me that I have to tell the doctor when I'm sick." And I can understand that bit of anxiety. Certainly what the medical community is saying and what respirologists are saying is, despite years and years and years of research and study into COPD, into exacerbations, or these things we call flare-ups, they still don't have any what they would call good markers to tell them what is going on. Meaning, we can do an ECG, the little electrodes stuck onto your chest, and determine have you had a heart attack or not. Look at the rhythm of the heart. They can do blood work, draw off blood when you show up in the emergency department, and they can go, cardiac enzymes are elevated, this is down, and they can very, very quickly figure out, have you had a heart attack, et cetera, and guide treatment. The challenge with the COPD exacerbation is that we don't have anything like that. We rely on essentially 3 classic symptom experiences, which of course are relative or relevant to the individual. So the first symptom would be shortness of breath. So if any of you are familiar, and I hope you are, with the Doctors of BC Flare Up for COPD plan, if you're not familiar with it, you could certainly ask Maureen. I'm sure she can make it available. I can make it available. It's from the Doctors of BC website. It's from their appendix on teaching materials that they would use for people with COPD. And basically what they would say is, if you are more short of breath than usual for 2 consecutive days, so for at least 48 hours, that potentially is indicating an exacerbation or a flare-up, okay? What they're getting at is that, yes, it is understood that with COPD, breathlessness with activity is a very regular, consistent symptom for most people who have COPD, meaning some people would say, well, I'm always short of breath. Understood. What we're trying to get at is, it's important for people to try and understand what their relative normal shortness of breath is, meaning very practical experiences. So if a person says, oh, okay, I get what you're talking about. I think what the respirologist said to me last time is that normally I could walk to my mailbox to collect my mail before I had to stop, or I didn't have to stop when I did that. And I had noticed that I wasn't able to get to the mailbox. I had to stop 1 or 2 times before I got there. I understand now that that was probably one of the first warning signs that I was starting to develop an exacerbation or have a flare-up, meaning it's in your life, in your daily routine, how short of breath do you get? How many times do you have to stop doing this or that, right? So that would be the first thing, noting shortness of breath. Has it changed? Secondly, it would be coughing. Some people with COPD will say, I cough every day and I produce a certain amount of mucus every day. Other people will say, no, I very irregularly cough or bring up mucus. So for the person that doesn't cough and bring up spit, if they start to do that, warning flag, make a note. For the people that always do cough and spit, are you coughing more? Meaning, is it now not just in the morning when you're waking up? And normally that would clear things and you'd be pretty good for the rest of the day. And now you're clearing stuff in the morning and you're still coughing up mucus during the day. That would be an important distinction. In terms of the mucus itself, I always make this joke and people cringe, but it's the bread and butter of our sort of business here. What does your mucus look like? Is it thick? Is it thin? Is it colored? Is it easy to clear? Is it difficult to clear? Is it stringy? These are all the things that we really want people to be intimately familiar with. So then they can say, ah, yes, my mucus is thicker, it's changing in color, and there's more volume. That's helpful to know. So shortness of breath, cough, and certainly mucus production. So those are 3 of the classic things we're encouraging people to be mindful of and watch out for. So technically, an exacerbation or a flare-up is just the different terms that we use. Exacerbation, for some people, is a really tough one even to say. So on the medical side of things, we have code. We would have AECOPD, acute exacerbation of COPD. That's a mouthful. So we sometimes use the word flare-up. Some respirologists even like to use the word lung attack, and that they're trying to get the message out that chronic colds that turn into chest infections that may or may not turn into pneumonias cause further damage or more progressive damage in COPD. So preventing exacerbations and treating them promptly are certainly 2 of the very important concepts in COPD self-management. So rather than a situation being like this, where I've heard this story many times, oh gosh, now I think I'm understanding that I've probably had 10 exacerbations over my lifetime, I never realized that having a cold that lasted for 1.5 months, like 6 weeks, was abnormal because it was normal for me. That would always happen. I'd get a cold in the fall or the winter and I'd be coughing my brains out, but never was sick enough to go to hospital. Didn't really think about going to the doctor's office to get drugs because I just thought this was what I had to suffer with because I had COPD. So exacerbations or flare-ups can be mild, meaning they get better on their own, so to speak. They can be what we would call moderate, where they definitely would benefit from prednisone and or antibiotics, which we can talk about a little bit later. And then a severe exacerbation is one that does require a hospital admission. And so there is good evidence that people who have more exacerbations tend to have a more rapid progression or worsening of their COPD over time. So related to now, part of the question that I think I remember noticing at the bottom of the page, there was a question about COPD and allergies. So I'll try and talk about two things at the same time. Most people with COPD, especially as their COPD gets worse, they will notice changes or variability in their breathing. You know, good day, not so good day, not so good day, better day, great day. And part of that certainly is likely to do with weather. Normally, the human lung is remarkably tolerant of very, very cold temperature, very, very hot temperature, high humidity, low humidity, changes in barometric pressure, meaning if the weather is cold outside, we feel it on our skin and we put a jacket on, but we don't really think about our breathing if we have COPD. However, people who do have COPD will often notice that their breathing is up and down and sideways. And certainly that can be the same when we look at what the weather's been for us over the last little while. A lot more sort of cold and warm and wet and damp and windy all over the place this last while. And so people with COPD certainly can notice that. So what we on the medical side of things are a little bit concerned about or wanting people to understand is that an exacerbation or flare-up that requires treatment is something that's persisting. So it's this 2 consecutive days that is persisting, quote unquote, not getting better, right? So it's not just, ooh, I feel bad today, my breathing isn't very good. Ooh, should I do something about it? No, it's more of a persistent shortness of breath. Even when I'm not doing anything, I'm noticing my breathing is more difficult. Related to the shortness of breath, we would want to know, have you used your salbutamol or your Atrovent or your Combivent, meaning your short-acting sort of rescue or reliever inhalers? Because typically if a person uses those and they get great benefit in the past, now they use them and they don't work very well, that's good information for them and good information for us. So it's this persistent breathlessness over at least 48 hours that doesn't get better. It's the more persistent cough with spit, again, that is unusual for that particular person and seems to be getting worse. Okay. Maybe the last thing I'll say about an exacerbation is just to clarify why there are 2 different types of medicines. So exacerbations typically involve the breathlessness aspect, and that's really what prednisone is for. So prednisone is a steroid taken by mouth. We hope that it's only taken for a very short period of time, typically 5 to 7 days. Some respirologists, if they know that they're going to be partnering the prednisone with an antibiotic, they'll say, let's make the prednisone 7 days because the antibiotic is quite often to be 7 days. So typically it would be prednisone for a minimum of 5 days, often for 7, same dose every day in most people. That dose is typically determined by a patient's physical size. So a large person, tall guy like myself, 6 foot, typically 50 milligrams. If, however, it was a lady who was, 5'2", the prednisone dose might be 30 milligrams, for example. But prednisone is really for shortness of breath. Antibiotic is for the active infection, the mucus in terms of the thickness, the color, the change in its appearance. And so very often, people who have COPD, who have an exacerbation, they're having an infectious flare or exacerbation. And so they would take antibiotic to treat the infection, the bacterial infection, and they would take prednisone to treat the inflammation that is resulting in the persistent breathlessness. So it's the two medicines at the same time. Now, we all understand and have seen the ads on TV from Bonnie Henry and seen the ads on buses as they drive by. Not all bugs need drugs, meaning most colds or flus, of course, that people get through the year, they're viral in nature and they don't benefit from antibiotic use. People with COPD are different though. We're all colonized with bugs, good bugs and bad bugs, in our gut, in our lungs. And so what happens is viral infections can trigger bacterial infections in people with COPD. So the concept of an exacerbation or a flare-up and having an action plan is the Canadian Thoracic Society, along with all other national thoracic societies, American, European, have said that one of the challenges that they see in clinical practice and one of the challenges that people with COPD face is, what do they do if they start to feel unwell on a Thursday or a Friday, particularly if we think about this weekend coming up? It's Good Friday, Easter Monday. If somebody starts to feel unwell over a long weekend or at any time, and they don't have access to their physician, they'll often have to wait. And then they do have to wait, and then maybe, Monday morning at 2, they call 911 and go into the emergency department. And at some point, the common statement would be, well, it's unfortunate that you waited so long. And the person with COPD might say, I wouldn't have waited so long, except that I had to wait so long. So the concept of an action plan is really meant to put some of the decision making, yes, one could say responsibility, but to put that opportunity into your hands to say, I've had these flare-ups before. I'm getting a better idea of what to look for. I now understand what my doctor, respirologist means in terms of being aware and recognizing these warning signs, because respirologists know that people will tend to have a similar pattern, not identical, but similar patterns. And so you can use that previous history and story to guide you to deal with the next exacerbation that could occur. There was one other thing that I was thinking of that I was going to say, and now it's sort of evading me. Isn't that terrible? Okay. I'll stop there. And I can certainly entertain questions afterwards, but was there one? Yeah, here we are. There was a question. Right. Oh, actually, these were the ones I think that I had put forward in terms of questions that or statements that people will make to me. So you can see there on the screen, sometimes I get so short of breath and I haven't done anything. The question being, can stress or anxiety cause shortness of breath? And certainly, absolutely, the answer is yes. And for some people with COPD or even asthma for that matter, they're intimately aware of this, and it can be very, very challenging and very frightening. So why does it happen? Well, it happens because when any individual is in a stress situation or having an anxiety response to something stressful, we do three things universally without conscious thought. We breathe faster, we try and breathe more deeply, and we change our posture, meaning we tend to hunch our shoulders up, become very tense or tight in the upper body. It's like if I heard a loud noise behind me, I would do this and I'd hold my breath for a moment. And, oh my God, what was that? And then I would slowly catch my breath. So the challenge then that a person with COPD has is that faster, rapid breathing with tightened or hunched shoulders, very, very tight upper chest, that causes breathlessness because COPD ultimately is a lung emptying condition, meaning the reason we talk about pursed lip breathing, blowing out like you're cooling soup, pacing, slowing breathing down, and posture is because the breathlessness experience isn't really caused by what most people would think is causing it, meaning, oh, I don't have enough air. I don't have enough oxygen. The irony with COPD is actually that the lungs are so full that there isn't any more room for air. In that with COPD, the lungs will always, always, always fill up. They tend to back up fuller than they should. And so the explanation that I give to people that I speak to help understand this is, think of the bathroom sink. You wash your hands at the sink, you turn the taps off, and you look at the water as you're drying your hands and you notice that the water isn't emptying out of the sink very quickly. Anybody, you don't have to be a plumber to know, oh, the drain's backing up. So if the taps were on full and water was pouring into the sink, but it wasn't emptying out the drain very well, you know that you'd have a flood. You'd have water all over the counter and on the floor. That's actually what happens with COPD. That's why we get you to do that miserable blowing test. We measure how well your lungs empty. That's how we confirm the diagnosis of COPD. In addition to your history and your symptoms and these things, we need to demonstrate, do your lungs empty efficiently or not? And in COPD, they don't, to varying degrees. So what that means is, if you breathe more quickly, your lungs have less time to empty because of that rapid breathing. And because they don't empty efficiently enough, faster rapid breathing means that the lungs end up backing up. And therefore, the symptom of breathlessness in COPD is not related to what your oxygen levels are doing. It's actually really related to the similar concept, and I don't say this to be funny or crude, but it's practical, it's true. How do any of us know when it's time to go pee? The reality is, urine is coming from the kidneys and going into the bladder, and the bladder is slowly but surely stretching with urine. Little baroreceptors or stretch receptors in the bladder start to send signals to the brain, and the brain starts to recognize that the bladder is getting full, and we have the sense of fullness that we can all feel. And so we know what that fullness feels like. I've got to go to the bathroom, that urgency that we have. The lungs have stretch receptors. And so in, pardon the expression, normal breathing, the lung can fill and empty very, very rapidly. Emptying the lung takes just the same amount of time as filling it up. In, out, in, out, in, out, in, out. In COPD, it's like in, out, and before you've emptied, oh, I got to take another breath in. That's what actually happens is these stretch receptors in the lung are starting to fire, and the brain is having a tough time interpreting that. It's saying, oh, breathlessness, breathe faster and deeper. That's how we normally deal with breathlessness. We walk up a hill, I simply breathe in and out faster and deeper. If I'm breathless, it's because I'm out of shape and I'm not, maybe I'm too fat, right? The reality with COPD, though, is that faster breathing causes more of this air trapping to occur. And so it's really this air trapping or stretching of the lungs and those stretch receptors that actually is causing the breathlessness. That's why stress or anxiety with no physical activity can result in people being very breathless. So the technique to reduce breathlessness during a stress or anxiety episode is the same breathing techniques that we would counsel people to use with walking, physical activity. Pursed lip breathing, just as Jenna demonstrated, blowing out like you're cooling soup, trying to breathe in through the nose. So cool the soup, smell the roses. Number 2, pacing, slow the breathing down to try and give the lungs more time to empty. People feel better. And the third is posture. And posture is a very important concept in terms of how this particular position of our shoulders or what the muscles of the upper chest and back are doing when we carry things. In that I will quite commonly hear in, say, for example, a man or a woman who is 54 years of age with COPD, and they're both painters. And they both talk about the fact that when they try and do the roller, they get unbelievably breathless. And that's because as a person has COPD that is getting a little bit worse, or the symptoms are getting worse because they're doing physical work, they're breathing in and out more quickly. And as that happens, the lungs are backing up. Well, what none of us would think about is that the diaphragm is the big domed muscle that separates our lungs from our gut. Normally it's very high and it pulls down, and that's how we breathe in, exhale, breathe in, exhale. Well, as the lungs are backing up with COPD, getting fuller and fuller with this trapped air, the diaphragm is getting flattened. The flatter it gets, the less efficient it is as a pump. So people become very reliant on this very shallow breathing, very high in the chest. And when the muscles involved of breathing are doing that all the time, you can't be using these muscles to carry things or to move your arm. And so carrying groceries, using a paint roller, even washing hair, that can cause tremendous breathlessness. Why? Because when the lungs are doing this to breathe using these muscles, those muscles aren't available to support the shoulder to move the arm around. So the bottom line is you can reduce breathlessness, reduce stress or anxiety by understanding that the basic concept or principle around the breathlessness experience of COPD is, ironically, the lungs are too full. They don't release air very well. They're very slow to empty. So really, we want to do two things that initially don't make a lot of sense. They seem counterintuitive. We want to blow out more than we breathe in, and we want to slow our breathing down. And when we're blowing out using pursed lip breathing, it's blowing out like you're cooling soup. It's not forced. You're not squeezing the air out of the lung. That does nothing beneficial. It's actually quite uncomfortable, and it doesn't do anything beneficial. Okay, I better move on to the next question just to make sure I don't run out of time, but hopefully that was useful. Can a person have moderate emphysema and not be short of breath? I think that was the question. Is that right?
That's correct. Yes, that's
Yeah.
on our chat.
Yeah. So you're right. People can have moderate emphysema, meaning emphysema by definition is really an anatomical description of damage to air sacs. So emphysema can only be confirmed by a visual look at the lungs, either a chest x-ray or the gold standard would be a CT. What do they call that? You know, a computized blah, 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 but a CT scan of the chest. You can have fairly significant damage to the air sacs of the lung before a person might actually experience breathlessness. So yes, the question is, can I have moderate emphysema and not even know about it, meaning not be symptomatic, but have a respirologist say, yes, you have emphysema based on this particular CT scan? That is true. The good news is that with that in mind, it demonstrates really how incredibly durable and over-designed the lungs are. Meaning I can see people with lung function as low as 30%. And yes, they get breathless if they walked up a hill, but they can still function. So the reality is we can lose 5, 10, 15, 20, 30, 40% lung function, and we're oblivious to it. In fact, many people are not diagnosed with COPD until the disease is fairly far advanced, so to speak. So on one hand, it's good that the lungs are amazingly durable despite all of the damage. On the other hand, that's why sometimes it's a real shocker for people to get the diagnosis because it's been going on quietly, unbeknownst to us. Okay. Sometimes I wonder why I take this inhaler. It doesn't seem to do anything for me. How does a respirologist know what inhaler to put you on? The reason that's actually a comment or comments that I've heard from people in the past. It is important to understand that certain medications have very particular purposes. So this is what I tend to use as an example. If I had a terrible headache, I would want to take a medicine that helped to treat the symptoms of my headache, right? So I would expect it to work. It would reduce my symptoms. It is a relieving medicine to make my symptoms go away or make them be better. However, if I looked at something like a medicine to control blood pressure, that doesn't really make me feel any different. You know, we all know that high blood pressure has often been called the silent killer because we don't have symptoms of high blood pressure. And yet high blood pressure day after day, week after week, month after year, year after year is definitely related to an increased risk of heart attack, stroke, and aneurysm. So certain medicines we take for preventative reasons, blood pressure medicines, other things we take for symptom relief, you know, something for my headache. And some of the respiratory medicines, we need to think of them in the same way. So the blue puffer, salbutamol, or the old trade name Ventolin, Atrovent, or Combivent, for example, they are meant to be symptom relieving inhalers. Sometimes they're called rescue, sometimes they're called reliever. We would expect to get some relief. So here's the first part of why I bring this up. If I had a situation, or maybe you had a situation like this, you're sitting, you're not doing anything, something happens, phone rings, you answer it, bad news. A person with COPD might say, oh my God, my breathing just went to hell in a handbasket. I became so breathless, and I took my blue puffer and it didn't work. Well, the blue puffer can only work to relax the muscles that wrap around the breathing tubes if they're tight. If, for example, the sudden cause of the breathlessness was really more related to a stress or anxiety response, the blue puffer won't help. And for some people, of course, that's concerning. Well, the blue puffer doesn't work. Well, it doesn't really work in the stress response. Pursed-lip breathing, pacing, postural techniques do. The other reason I put this up is that depending upon the individual's type of COPD, so to speak, some people, the damage in the breathing tubes is fairly persistent and not very responsive to inhaler medicines. In other people who have COPD, we give them the blue salbutamol puffer, for example, during their test, and we get a whopping big improvement. So in some patients, when they go on an inhaler, the response that they have will be, wow, fantastic, really notice that difference. In other people, it would be, I don't really notice that that does much for me. So we know that both of these situations can occur. In both of the situations, though, whether a person doesn't get a symptom response or whether a person does, long-acting or 24-hour effective medicines, so Symbicort or Advair or Anoro, Incruz, all of the different long-acting medicines that are out there, they do have a preventative value, meaning in a person who is having a lot of chest infections, who's having these exacerbations, respirologists will put you on some of these inhalers to try and reduce the likelihood that you have another exacerbation. The inhaler may or may not necessarily make you feel better, but they know that it's a good preventative strategy. So, depending upon the person with COPD, some people will get tremendous benefit from an inhaler, other people less benefit in terms of symptom change. But when we look at these longer lasting or what we call preventative treatments, whether it's not much symptom benefit or tremendous symptom benefit, a certain amount of the reason for that inhaler is to prevent future problems, if that makes sense. A little bit like the blood pressure medicine. We don't really feel that it does anything for us today, but we know it has value down the road. Okay, next question. Sure. What I will do for the purposes of this in terms of proper inhaler use is I'm not going to get into the specifics of them to start with unless we have time. Really what I want to talk about are the 3 essentials that I hope, or any physician respirologist would hope you follow with how to use an inhaler properly. Keeping in mind that not all people will be able to stand for reasons of balance or they're in a wheelchair. So keep in mind that we all have to be safe. But the first recommendation is always, 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 always stand up when you use an inhaler. It may sound, well, that makes sense because that's what I always do. A lot of people will take their inhaler when they're sitting at the table taking all of their other medicines that they might take with water. Stand up to do inhalers. We want to ensure that we can take as full and deep a breath, and we do that better when we're standing, meaning we would never we would never see a singer or a choir perform sitting down. Standing up, better, shall we say, lung expansion or excursion, right? So number 1, always stand. Number 2, you always want to be looking forward. So if you imagine that I'm taking an inhaler, and I'll just pick on this particular one, not because Symbicort is bad, but it would be quite common for me to see people do this and then lean forward. Now they may lean forward with no conscious thought. They're simply going towards the device. We hold something in our hands and we're drawn to it. They may, however, think, just like any powder device, oh, well, I need it to be upright, otherwise the powder will fall out. I should do it like this. No. All powdered devices, any inhaler, doesn't matter what we're talking about, will work in the horizontal position. So what we want to do is we want to be looking forward when we're taking an inhaler. Imagine that you're looking out the window. If you really want the textbook perfection, it's a slight lift of the chin. Nothing like that, but if we were doing CPR, as you may or may not know, One person is doing this. If somebody else comes along, that gentle lift of the chin. So if you imagine that you're looking at where the ceiling and the wall comes together, except if you're in your bathroom and your bathroom is small, right? So basically it's you're looking forward, slight lift of the chin, always bring the inhaler to the mouth. So that's number 2, looking forward. Number 3, really, really important, the more severe your COPD is, you want to blow out using your pursed lip breathing like you're cooling the soup before you inhale. So I'll just give you a demonstration with Symbicort as an example. So pretend I'm standing. I hold it straight up and down, like vertical. Well, there we are. Turn, click. Doesn't matter left or right. It's just turn till it stops. Turn it back until it clicks. The device is now ready. I will now hold it off to the side so I'm not blowing any moisture into it. I will blow out. Bring it up between my teeth and lips. And then I will try and hold my breath for 5 to 10 seconds. The more severe the COPD, typically the tougher time a person might have to hold their breath for 10 seconds. So I always encourage people to hold their breath for up to 5 seconds, as long as 10 if you are able, but don't sweat it or worry if you can't hold your breath for 10 seconds. So again, the universal technique, regardless of the inhaler, stand, look forward, blow out, as if you're cooling soup before you inhale. Now, I'm also happy to demonstrate particular inhalers if people would like, but that's really the primary message that okay. I understand there is a new type of medication on the market, 3 medicines in one. You're right. What is your opinion? Well, I always have to be careful. So this is the type of device. This isn't the actual medication. I'll show you which one it is. It's that one right there. Trelegy ellipta. So Trelegy is the fancy drug product name. It's manufactured by GlaxoSmithKline. Trelegy is 3 medicines. It's an inhaled steroid. It's a long-acting bronchodilator, one of the ones that we would call a LAMA. So this is where it can get a bit complicated. And then it's another long-acting bronchodilator that we would call a LABA. Okay. So LAMAs and LABAs are different families of long-acting muscle relaxers. And so bronchodilators or muscle relaxers are the primary therapy in treating COPD. So in asthma, steroid-containing inhalers are the primary strategy for treatment. So it's why respirologists or physicians are very particular, and they really want to try and tease out, is this asthma? Is this COPD? Could this be COPD and asthma together? Asthma, COPD overlap. So in some people who have either what we would call asthma, COPD overlap, so maybe they had allergies as a kid, frequent courses of bronchitis when they were a child, a diagnosis or presumed diagnosis of asthma child because of breathlessness that was unusual for them compared to their siblings or friends, right? And then they either started to work in an environment where smoke was prevalent or they were a smoker themselves. So it could be that 40 years down the road, the asthma never went away, but the thing we're primarily paying attention to, worried about, is the COPD. They may have both. So in a person who has a pre-existing diagnosis of asthma and COPD, lung damage, being on something that contains a steroid for the asthma and then the bronchodilators for the COPD, 3-in-1, Trelegy might be appropriate. The other class of person that might use Trelegy would be the person, and this is the more likely initial reason for Trelegy, is they've got COPD, they don't have a history of asthma, but they have a history of exacerbations or colds turning into chest infections. So respirologists know that having people on the 2 bronchodilators, the long-acting muscarinic antagonists, these LAMAs, of which things like Spiriva or Incruz would be members, and then a LABA medicine, a long-acting type of Ventolin essentially, that LAMAs and LABAs in people with more severe COPD who are prone to exacerbations makes sense. In some people, though, that still doesn't seem to reduce the incidence or the number of these exacerbations or flare-ups. And a respirologist or physician might say, do we need to add in a tiny little bit of steroid to try and reduce these exacerbations? And that's where Trelegy more commonly would fit. So it's, you need to be on a LABA and a LABA, but they also think that you would benefit from a bit of a steroid. Will put you on Trelegy. Not to confuse the matter, but simply because people will ask this and they may read it. There are some people with COPD who do not have asthma, and they don't necessarily get sick that much, but they do really quite well with inhaled steroids. So there is a small subsegment of the COPD universe that doesn't have asthma. They don't necessarily get a lot of exacerbations, and they do benefit from a little bit of steroids. So I just wanted to be clear about that. Can a bronchodilator be too strong for you, affecting your throat and causing a cough? It certainly can. The question really regarding any inhaled medicine is, when does it cause a cough? So if I was using, and I don't say this to pick on it, but if I was using this particular inhaler, this one happens to be there we are. It's made by Novartis. It's a little puffer that would have a medicine called Seabree. If it was a bit yellower, it would be Ultibro. The bottom line is this particular type of inhaler involves a powder. And so when some people inhale that powder, it could hit the back of the throat and it can make them cough. Another medicine that could cause a cough at the back of the throat would be I'll answer that question about Trelegy, the inhaler I was talking about, the 3-in-1, Trelegy, Trelegy ellipta. Thanks, Maureen. If we're talking about cough, Spiriva Respimat is the mist inhaler. Some people will actually get a cough when it hits the back of the throat. So it's important to know whether we're having a cough when the medicine hits the lung, what we would call a more true side effect, or whether it's a side effect or irritant because the back of the throat is sensitive. So bronchodilators or muscle relaxing medicines do not tend to cause the same degree of hoarseness or voice issues that steroid containing inhalers would. So we tend to see more incidences of dysphonia, for example, in people who use an inhaler that has a steroid in it. Certainly thrush or yeast infection of the mouth only will happen in people who are using a steroid containing inhaler. Now, any medication that you spray down the back of the throat potentially can irritate the throat or the voice, whether it's a bronchodilator or a steroid containing inhaler. So certainly one of the things that we would want to do is make sure that your inhaler technique is good. So whether you're using this form of powdered bronchodilator or the mist form of bronchodilator or any other type, we would certainly encourage you to have good technique. If a person is asking specifically about Spiriva Respimat or Inspialto Respimat or Combivent Respimat, some people, when they breathe it in, if the back of the throat is dry, they will tend to cough more. So believe it or not, having a little sip of water before you take Respimat inhaler can, for some people, will reduce the cough that they get when they inhale it. So that would be sort of a suggestion I would have for that.
All right, so that is actually the end of the slides.
Okay.
We have about 5 minutes left before Mark has to go. So if anybody has any questions, please type them into the chat or raise your hand, and I will unmute you. You can ask your question in real time. Otherwise, Mark, do you have any tips on sort of like what people can do to improve their lung health?
Certainly, you know, the only thing that has been known to slow the progression of COPD is quitting smoking. So if somebody was still an active smoker, certainly we would clearly counsel them to do their best to get off cigarettes. I mean, ultimately, whether a person is smoking marijuana, whether they're using a vaporizer for marijuana, whether they're using vaping with nicotine, anything that is inhaled into the lung can be an irritant. Now, clearly people will have different reactions to different inhaled substances. I can meet some people who, they used to be a 2-pack a day smoker. They've finally been able to quit. They went on to the vaping and now they can't even vape without it being an irritant. They'll say, "What's up?" And I'll say, "Well, your lungs are just too cranky. The muscles that wrap around the breathing tubes are clearly just reacting to that." So ultimately, the only thing that has been shown to be effective at slowing the progression of COPD is not inhaling anything. So there was a question about essential oils. The reality is some people very much enjoy essential oils. We know that salt therapy for years and years and years has been quite soothing to many people. The reality is some people use essential oils and they think they're the greatest thing since sliced bread. As long as they're not causing you to cough or wheeze, or you don't think they're related in any way, shape, or form to you getting, frequent colds or chest infections, you could use them. Other people that might try essential oil saying, "Oh my God, that's awful. Who would want to do that? That's an irritant." So you can't say universally that all people should or shouldn't do this. What we would say is trying to reduce the particulate exposure of anything is helpful. So, very, very smoggy, heavy days in terms of, air pollution, the air quality health index is, 8 out of 10 or 10 plus when we had the forest fires. Avoid that to the best of your ability. Don't go outside, minimize your activity, change appointments if you need to, because certainly people with COPD can have what we would call a non-infectious flare of COPD. So they're doing well, particulate smoke exposure from, say, the forest fires in Washington, Oregon, and California, and people can get really, really, really sick, lots of breathlessness, very, very congested. They don't necessarily feel that they have an infection. They may not. So they have a non-infectious flare of their COPD simply from particulate exposure. So, if somebody says, "I love to do hobbies and crafts," make sure to the best of your ability that there's good airflow. So if you're using, a soldering gun and there's smoke, have a cross flow so that it's blowing that away from you. Or if you're using different types of glues or any sort of an acrylic, again, the same thing, breathing in the small amounts of those very, very strong hardeners that are in nail polish or paints if you're doing model airplanes, those can be quite irritating to the lungs. So being mindful that, yes, with COPD, reducing exposure to irritants and particulates is important. We're all trying to avoid living in a bubble, unfortunately, as we've had to for the last year and a bit, but certainly limiting your exposure to particulates is important.
All right. I guess that concludes our webinar for today. Once again, thank you so much to Mark and also to Jenna for being our guest today. We've certainly learned a lot. And this recording will be available on the BC Long website for on-demand viewing at a later date. Yeah, you want to add something else? Yeah, go ahead.
I just wanted to add one comment, and hopefully people are very much aware of this. For the longest time, respirologists and researchers have looked at the relative value or merit of different interventions that people can make in their own lives or would be recommended to them. And absolutely consistently, without fail, when you look at the relative merit or benefit of pharmacotherapy inhalers, and then you look at the relative merit or value of exercise, it's a 50-50 split. Meaning the great irony really with COPD for many people is that exercise is one of the best therapies or treatments. And yet breathlessness, of course, is such a primary problem for people with COPD. So I know there are many people out there who really struggle in some ways. That they're quite agitated and irritated. You keep telling me to be more active and yet I can't because I'm breathless, etc. And that's really why one of the things that I talk about, I hope enough, but not too much to drive people bonkers, is that breath control. Understanding that strategies to control breathlessness really do work. Pursed lip breathing, pacing, posture. They really work when you're walking up a hill, blow out to go up. going up a set of stairs, blow out as you're going up a set of stairs. So the ability to control breathlessness or reduce breathlessness, both for the immediate control of symptoms in the moment and to reduce the fatigue or tiredness that comes with breathlessness, that is essential really to support you to be able to do the exercise or the activity as Jenna was demonstrating. And anybody that's ever done any type of rehab program, they are going to say, absolutely, I get it. I was hesitant, doubtful, not sure I could do it when I started. And I know that I feel better at the end. Meaning ultimately you don't exercise to make your lungs better. You exercise to make the rest of your body fitter and stronger to deal with the fact that your lungs don't work quite well. So people can be physically fit, but have COPD. So there's my last rant.
Thank you, Mark. That was great.
You're
That was
welcome.
really
Very
good.
much.
All right. Thank you, everybody.